talking about innovation in diagnostic technologies and the challenge posed for governments. So I thought, as I've never been a discussant before, I better tell you what I'm going to do, because I think there may be, just so you get a sense of where I'm going with this. So one thing I'm not going to do is try and critique what Andrew's just said, largely because I have recognise a lot of the things that he's saying, particularly from the particular perspective he's coming at it from, and I come from a rather different perspective, which I'll talk a little bit about in a second. So what I'm really trying to do here is just to pick up perhaps some additional themes as they occur to me from my particular perspective, both in the nature of innovation and also the nature of governance, and some practical experience that I have being involved in NICE, which attempts to govern this area. So what is my perspective, first of all? Well, once upon a time I was a doctor, albeit for a relatively short period of time, about 5 years as a junior doctor. So I have grappled with some of these problems, although it's quite a long time ago. Trained in public health, which I think one of the perspectives that I bring from my public health background is a responsibility for screening, so there's obviously the use of tests in the context of screening. But thereafter, within public health, I specialised in health technology assessment, which I think is closely related to evidence-based medicine. I'll mention later on Mildred Blackster's article about her experience being on the receiving end of diagnosis and some of the comments that she makes about evidence-based medicine. But really, health technology assessment is about trying to give people a handle on, it's new, but does it do any good? So, as a society, do we think that these things are going to add value? And if so, if they do add value, how much would we like to pay for them? And what other things do we need to forego in order to make these particular things happen? The next thing, which is within health technology assessment, I also became interested in the evaluation of tests, and I think that's largely me revisiting my early career as a junior doctor, but also to a certain extent revisiting some of the experiences I had thinking about screening as a public health practitioner. And as I said, as Susan mentioned, I've been involved in that context of thinking about diagnostics as part of the Cochrane collaboration, and most recently as part of NICE's diagnostic appraisal, which we'll bit about. There's a bit of a preamble about definitions, which, although a bit tedious, I think are probably quite important because they introduce a lot of confusion. And people talk about diagnostics, and you'll notice when I talked about my interest, it's not actually in diagnostics, it's actually in tests. So tests are probably what it is that we're interested in. So we measure things with tests. The things that people develop are tests. They're not diagnostics as such. Diagnosis is one of the things that we might do with those tests. In other words, the labelling of somebody comes along to me as a doctor with a set of symptoms, and I want to tell them, if you like, what the underlying disease process is, firstly for informational purposes, but secondly to help direct the treatment. So that's one particular use of a test. But there are other very important uses of the test. So prognosis is a separate use of a test and helps give people and patients information about what their long-term outcome might be. So it's not about whether they've got a particular disease or not. It's giving them information about what the future holds for them. And it's usually preconditioned by the fact that you have a particular disease, and therefore your outcome, your survival will be, in 5 years' time, you have a 50% probability of being alive. So that's another very important additional use of a test. Monitoring is a very, very important use of a test. In a sense, people will be familiar with chronic diseases. Quite often people use tests to tell you how you're getting on with your disease. Do you need more treatment? Do you need more antihypertensive treatment? Do you need your diabetic medication altering? So that's another use of a test. And then there's screening itself, which you could say, well, actually, that's just an early type of diagnosis, but those people who've been involved in screening will know that there are quite significant differences between use of a test for screening and use of a test for diagnosis. And why am I going on about this? And the problem is that tests can be used for different things. And if we're not careful, we're looking at an innovation as a diagnostic. And in fact, it's a test being used for a different purpose. The test has been around for ages. But actually, the innovation is we're using that test in a different way. So we need to be quite clear. I think we need to unpack a little bit about what it is we mean by test, what it is that we mean by diagnostic. And my preference is, my if you plea to you when you're thinking about this and the social consequences of introducing new diagnostics, actually think about, well, what's the test and what's it being used for? And that will help avoid some errors where actually you're not thinking, you're actually looking, you're making some judgments about the impact of a diagnostic, whereas in fact it's a test being used in a particular way, and the test could be used in other ways as well. So it's a simple point, and I think may well help. So the nature of innovation, I don't really want to add a great deal, just to what Andrew has said, other than to say that I think that it's worth stating the obvious, that innovation, I think to most people, just means something which is new. You know, novelty, we live in an age which is, if indeed that's always been the case, that novelty and newness is a very attractive feature of all sorts of things. But there is an associated suggestion that there is an advance to that. So when people say, oh, I've got an innovative technique, they say, they're appealing to you, this is new, we haven't done it before, but there's also a sense that, yes, and it's doing something better than it was before. And when you actually, often when you look to see what's the information on which that advance is being based, it isn't actually there. So the novelty itself may represent, and the other thing about novelty is, of course, it's in the eye of the beholder. So Andrew tells me that there's an innovative technique in molecular biology for imaging haematology, and I'll go to a specialist in the area and say, well, that's old hat. We've been doing that for years. We just only happen to do it in a university centre. Similarly, many of the things that you hear about, particularly in the newspapers, as being innovations, new things, maybe 20 or 30 years old, some of the basic things. So actually just the nature of innovation in itself is subject to your perspective. So considering a little bit, I think one of the things which I would suggest is that where the innovation comes from could be quite an important clue as to whether it represents an advance or not. And certainly the history of medicine is punctuated by great improvements in healthcare associated with new measurement techniques. So we can think about things like the microscope. Allowed us to see things which we were never able to see before, and as a result completely transformed people's views about the nature of disease as they were occurring in the Middle Ages. And then people then understood that they were due to organisms. So there's a sea change there. So clearly there is the capacity for new tests to make huge changes. And I would say, certainly electron microscopy is the next stepping stone in that, allows us to see at an even greater level of detail, and discoveries came out of that new concept, new understanding about the nature of the disease as well. So actually where the innovation, how the innovation has come about, is it something which has led us to a complete, transformed our view of disease? I would say might well have a greater opportunity to advance how we manage patients, patient outcome ultimately at the end of the day, than the other end of the spectrum, which we also see a great deal, which is technology looking for a solution. So all sorts of things made smaller. So a very good example, somebody came to me a couple of years ago and said, well, I've got this great new handheld ultrasound, and it's just a feature of the fact you can do things a lot smaller. So rather than having to go to a clinic in a hospital to have your abdomen scanned or your pregnancy monitored, we've got this handheld ultrasound machine which a doctor can carry around in their pocket. But when you actually ask people, and you ask the developers, they say, well, did you have anything particular in mind? Is there anything that you think this does which we couldn't already do, other than the fact that people can carry it around? And actually what becomes clear is that people didn't have anything specifically in mind. It was just that the technology was available and we could now make machines which were much smaller. And I would put it to you that in terms of understanding where that innovation has come from, can possibly help us, and understanding more about where these innovations come from could possibly be important in making a judgment of whether it's going to advance the treatment of disease or not. So on to governance, right. Well, here I do feel in a slightly stronger position to comment, because my first observation is what governance? The terms Wild West, law of the jungle definitely flooded in, it came into my head as we started to talk about governance of testing. And In Europe, the main form of governance is you've got to achieve a kite mark. And people may be surprised to hear that the main thing governing the introduction of new tests is a kite mark, because you'll probably be more familiar with it on household goods. So the same legislation which governs the introduction of household goods, toys, all those sorts of things, is the legislation which is used to govern tests. Some of you might be reassured by that to say, I'm very glad to know that the same standard is required to introduce a new washing machine as it is to introduce a new test, which might mean that I'm more or less likely to be misdiagnosed with cancer. Or you might say, well, actually, I'm a little bit worried that that's all that's required, because actually all the manufacturers or all the producers of the test are required to do is to substantiate whatever claim they wish to make about the test. So the test only claims to measure the amount of serum rubral in your blood, and they are able to demonstrate that a given concentration is accurately detected, then it will pass its kite mark. If you want to claim, as certainly people in North America applying to the FDA do, that this improves patient health or people are likely to have greater survival, then clearly the amount of information that you need to provide and the amount of corroboration that you need to provide is much greater. But it won't come as a great surprise to you that if you have an option of introducing a test just on the basis of whether it does what it says on the tin at a very low level, then most manufacturers do take the line of least resistance. So governance, what governance? We don't actually have an awful lot governing which tests come to the fore. And as with all things, the skill of the company, the marketing department, and the depth of the company's pockets probably has as much to do with it. But then you realise that many companies producing these tests are very small organisations, so they don't have very deep pockets, and they certainly don't have very sophisticated marketing departments. So actually what you end up with is a feature of randomness. The things that we use, the things that are introduced, there is a large random element to what is actually gets put forward. And that has led to growing concern in many countries, developed and developing countries, about pressure on costs, but at the same time, certainly in the UK, another bit of the dialogue has been, this is actually quite a good money spinner. This could be part of economic growth as well. So certainly we've heard had comments fed to us as part of the Diagnostics Assessment Committee in NICE that, well, don't be too hard on this company. There could be, part of the economic recovery. So on the one hand, we've got huge concern about, sort of, if it's a foreign company and their test costs a lot of money, then we've got to be thinking about, we've got the opportunity to constrain inappropriate diffusion of innovation. But if it's possibly something which is being developed in a local hospital and doesn't cost so much money, then we might be encouraged to, be realistic in your assessment of its strengths and weaknesses. So there's some interesting things going on in governance, but I would say that the main thing is that it's an absence of governance, which I think actually fits in with what Andrew was saying. So on to a little bit about what NICE has been up to. Well, NICE deals with the problem of governance in two ways. First of all, it deals with the level of devices, of which tests are only one, and it receives invitations currently from manufacturers about whether they have got any devices which they think NICE would like to look at. And quite often they're looking for the NICE stamp of approval to help them get their product out there, and the stamp of approval from NICE is seen to be something which they're prepared to pursue. And that's done by something called, all devices go into a pathway, an evaluation panel called the Medical Technology Evaluation Pathway. And it's from there, they make a decision, a triaging decision for tests, on whether there seems to be any value in looking at this in detail. There may be some very simple examples of tests where it's just that the test costs less than the existing test, and the Medical Technology Evaluation Panel says, well, it's pretty obvious, but as it costs less, or the price is less, we're happy to say, well, this test does exactly what another test does, but it does so at a lower price. So the only bit of the evaluation that I'm going to talk about is the next level down, where there seems to be a important trade-off either between cost and accuracy, in other words, how good it is at getting the right diagnosis, or cost and the likelihood that it will make a difference to the patient outcome. And so far, the Diagnostics Appraisal Committee has looked at about 10 pieces of guidance over the last 2.5 years. So the first thing you'll be able to say is the process is time-consuming and it's certainly complex. It usually reveals much greater uncertainty about the presence of advantage. So this idea, that going back to the definition of innovation, this idea of advantage is sometimes very, very difficult to get to the bottom of. Cost effectiveness modelling is an important part of what NICE does, and if people want to ask me a bit more about, well, what do you mean by that, I'm happy to expand on that in the discussion section. But it's definitely been seen as quite successful in NICE's ability to deal with drugs. So it's been one of the things which they've been able to use to help, they would say, improve their decisions on new drugs. My observation in particular of the working of the Diagnostic Appraisal Committee is that it doesn't work in doesn't have quite the same level of success for diagnostics. Again, I think about why that might be. And the thing which is particularly emerges, although the main consequences of a new test might be relatively clear and demonstrated to some extent, the extraneous consequences of the test are either, well, probably not even considered and certainly not investigated to any depth. So when we receive cases from companies putting forward their test, we get quite a lot on, this is what we think it does, not so much on, here's some evidence which tells us, here's some information which corroborates that it does what it does, and virtually nothing at all with, well, what happens if it goes wrong, or are there any unintended consequences? And I do wonder, although this is definitely another personal observation, there seems to be less companies coming forward now than there were 2.5 years ago, and I wondered whether that's because there has been a predominance of the decisions coming out of the NICE Diagnostics Committee has been more of the, we're not really quite sure what this is doing and why it is, how it's going to add value. So I think the companies may well be voting with their feet, saying, well, this is not giving us the stamp of endorsement which we were hoping for. It's just giving us a long shopping list of other things which we need to do. No, thank you. So the last thing I just want to say a little bit about, and it's less a follow-up on Andrew's observations and more a reflection on the Mildred Blackster article, which I was moved to read in preparation for this. And that's just for those people who haven't come across it, it's her description of her experience when she was diagnosed, when she went along to her doctor with a shadow on her lung and what happened to her subsequently. And I think what this really highlights to me, and what I'd like to put back to you as another issue which you may want to consider, is that uncertainty is really a key theme. That uncertainty is a very important consideration, and it's an uncertainty at two levels. So there's the uncertainty which I've just alluded to, is that we're uncertain about whether new tests offer an advantage, and I think there are some arguments we said we will probably never be completely certain about, particularly whether introducing a new test improves patient outcomes. So if we introduce a new molecular marker for hematological malignancies, will introduction of that subsequently lead to an improved survival for people with hematological malignancies? That's a very tall order from an evaluative point of view. It's ideally what we might like to know, and we want a test associated with that. But the cost of getting that information itself may be prohibitive, and certainly the timescale required in order to do that may be very challenging, because by the time you've got the answer to it, there's another version of the technology on the market. So there are some difficulties about that, and uncertainty is at the core of that. But more importantly, I want to, again, I feel it is reasonable to say that most doctors are actually, if you ask them about diagnosis, they do not feel that this is a certain process at all. Diagnosis is a fundamentally uncertain, is a fundamental uncertainty attached to it. Most tests that we use do so with a degree of error. We can talk a little bit about the nature of the error, but 10% error rate of getting the label correct is not unusual. That's the norm. So what I'm saying is that if 100 people, as in Mildred Blackster's experience, were given a PET scan, 10 of those 100 will get the wrong label. Either they will get a diagnosis that they had cancer and they didn't have cancer, or they would get a diagnosis of all clear, but actually they did have cancer. Now, and I'm saying that's a good test, so you can imagine what some of the bad tests do. And so what I would invite you to think about is, well, where do we see that fundamental uncertainty? Where is that reflected in the discourse that was going on between the patient and the doctor and the medical profession in that description of that experience? The other thing is that there's absolutely no recognition in that description that the uncertainty, an implication of the uncertainty in the process actually invites greater patient participation. So if a doctor doesn't know what is the right treatment for a ward, doesn't really know what the diagnosis is, it seems to me, and most people involved in this process, that if you're being honest about it, then there is more opportunity for patients to exercise discretion or their own judgment about whether they should go on to further treatment or they shouldn't, because there's fundamental uncertainty about it. And the last thing is that we've done some research, and other people have done research, that the medical profession itself is poorly understands the nature of the uncertainty that it's dealing with. In other words, it professes great certainty when it makes diagnosis. But when you look at how doctors behave, when you ask them about particularly the meaning of some of the evaluations which are available, that information is already there, and ask them to demonstrate how it's reflected in their practice, they sometimes struggle to do that. And I think it's quite interesting to think why that is the case. And I think that then feeds back into a throwaway comment that Andrew made. He talked about the clinical interpretation. I do wonder whether the nature of clinical interpretation demands a bit more, a closer examination. What do we mean by clinical interpretation? What do doctors actually do in that clinical interpretation? Because it seems to me, if we're talking about innovations, that it's going to be a rate-limiting step. If doctors aren't actually as good at this clinical interpretation bit as we think they are, or they're actually struggling as much as the patient is with this respect, then all the innovations under the sun are going to be limited to some extent by the ability of doctors to either understand the information, to convey that information to the patients, to translate that information into treatment decisions which are consistent with the performance of the test that they're looking at. So my final thoughts was wondering whether, although innovation is clearly quite an important hook on all this, whether it's the diagnostic process itself which is the problem. In other words, although we tend to think, well, the innovation is making it more of a problem, and that may certainly still be the case, whether it's more about the diagnostic process that we've never really got to grips with. Even with the existing technology, doctors and patients and society is to some extent challenging at dealing with this. So we could well have had, as a talk for today, diagnostic technologies and the challenge posed for governments, just diagnostic technologies, existing ones as well. I think I'll stop there.
Observations. There's some of the issues that I raised, but then you took the opportunity to very, I think, constructively, productively raise a whole series of questions and points about, particularly in terms of innovation. I was struck by your, particularly from the sharp end we see in NICE with these diagnostics appraisals committee, where you're getting a whole range of different types of submissions from companies for approval. And in that context of that experience, where you made the observation that quite a lot of the innovation products and devices received reflect a randomness of innovation. There is a sort of assumption made in much of the, I suppose quite a lot of literature about innovation systems, that the very phrase innovation systems suggests coordination, suggests integration, suggests where systems do tie up. Now, of course, in some contexts, like in the world of software, there is a set of integrative ways in which Apple ensure that you buy their products in a series of ways, and there are over-determinations of innovation systems which are structured in such a way as to ensure that people sell products. But that can be overstated, I think, and I think the randomness idea of innovation is something we should explore a bit more, not least in terms of whether that randomness in and of itself actually produces a greater flexibility of the use of innovation systems, and perhaps goes back to my point earlier on about how context produce an additional randomness to it. So the randomness of that device is partly reflected in the variability of the context in which it's taken up, and adds further differentiating characteristics to the meaning of innovations themselves. So I think that provisionality, that provisional aspect of innovation is something we could explore, I think. The other point, which was a very important point too, was which I hadn't picked up in my comments, was the unintended effects, unintended consequences, I think the phrase used was extraneous consequences of innovation, those sorts of things, where in part the very producers of innovation are not sure, the very producers of tests are not sure, but particularly it may well be the case that NICE or other types of regulatory oversight committees themselves, A, haven't got the time, or B, haven't got the information to know how to deal with those extraneous contingencies. And of course, it's those contingencies that can accumulate, multiply in healthcare systems, which produces unwanted adverse effects to the technology of innovations. We see that, of course, in the drugs world, which is why it's quite interesting to see other people marshalling other types of information, like the crowdsourcing, to capture these unintended effects of drugs in the context of patients. And then I thought, finally, your crucial observation about we should focus our attention on clinical interpretation as a process, and the ways in which we should be thinking about, notwithstanding how diagnostic technologies and diagnostic tests may have shaped diagnosis itself, we should be thinking about how interpretive judgments are made by clinicians in the present context. And of course, most clinicians will be dealing with patients in, for example, multidisciplinary groups where a case is heard in a clinic with 7 or 8 clinicians around the table, bringing their own particular interpretation. So interpretation is very rarely just one person, it's a whole group of clinicians working together, radiographer, anaesthetist, cancer specialist, whatever it may be. And they'll be all looking at, say, cancer patients in a particular problem in a case inquiry. So how those interpretations multiply, bring together, and add to our understanding, but also the possibilities of quite diverse understanding. So the 10% error rate as a given diagnosis can be given an additional impetus, as it were, to be not so much errors, but increasing complexity as to what is brought to the table to judge this particular pathology, where you have multidisciplinary teams working with a case of a patient. And I've observed quite a lot of those types of occasions, and it's been quite interesting, and I'll just mention this last point, to follow the pathway of those judgments as they then follow the patient, or the patient follows that pathway. And I think the idea of pathway, I think you used the phrase at one point, pathway. You talked about NICE's Medical Technology Evaluation Panel and the pathway, as it were, to be explored. If we think about pathways, we might be able to think about that in terms of pathways of workability of these types of tests and so on, in the diagnostic context in which they're useful, and pathways of accountability or governance, and whether these two actually intersect and how they intersect. We want to think about governance and interpretation and diagnostic as a trio of aspects at work shaping the pathways of both treatment but also accountability. So, my thoughts.